I'm Deb and I work for one of the national drug treatment providers, so Turning Point, and I have a harm reduction focused national role.
And I'm Maddie. I am one of the conference directors at Harm Reduction International, and I also help to run HIT.
So we're here in beautiful Liverpool today, which is the birthplace of harm reduction in the UK, and we want to talk about the real need for refocusing and reprioritising on good quality harm reduction services across our country.
Yeah, harm reduction slipped by the wayside a little over the last 2 decades, and we want to talk about exactly what we can do to put the focus back on harm reduction, what easy steps we can take starting today to make harm reduction more accessible for more people.
My name is Peter Furlong and I'm the National Harm Reduction Lead for Change, Grow, Live. I started volunteering back in 1996, I think it was. Driving a cab at the time around Liverpool, and it was a case of genuine compassionate curiosity that led me to do voluntary work, wanting to find out what was going on all around me with friends and family. Then got a job as an outreach worker in Liverpool, learned from some great people, and went on to then be an outreach worker in Sefton. Spent a long time working in Sefton, building up service provision, and haven't looked back really. Still enjoy the job, still love every day going to work, and we've still got a lot to do.
Okay, so we're at Maryland Street, which is just here behind me, and this is where sort of a lot of people talk about harm reduction being the birthplace. Born in Maryland Street and what was later to be known as the Maryland Centre. Originally in this building here on the left, it was the health promotion shop where needle and syringe exchange first started in the UK. And lots of people talk about the Maryland Centre being the birthplace of harm reduction, not only just in the UK but globally, and that's because what later became known as the Mersey model of harm reduction was held in such high regard by other parts of the country and then the rest of the world, so really quite a significant place. Later on, after starting a bit further up the street, the Maryland Centre moved to this building here, which is now student accommodation by the looks of it. But for many years the Maryland Centre operated out of here. This is where I first got my first job as a needle and syringe worker and outreach worker. And it went on to become known across the world, visited by many people. Back then, lots of the money and the effort was HIV prevention, but that later sort of grew as the problems emerged around other bloodborne viruses. Around that same time, in the late 80s, Dr. John Marks was prescribing diamorphine in Widnes originally, and again that became known as quite an excellent model of harm reduction.
But also you've got a whole population of people who are using drugs who don't feel perhaps traditional treatment services are relevant to their drug use as well. You know, we were talking before about like ketamine use and other types of drugs. And if we want to be able to reach people to give harm reduction advice to that group of people, they've got to feel that the door they're coming through is relevant for them to come through that door. And I think when we predominantly are still in those opiate-based side of things and alcohol-based treatment side of things, lots of people don't feel there's anything in there for me, so I won't push that door open and even step through and go, well, what's going on in here kind of thing, because I don't know to go and look for it kind of thing. So I think it's with harm reduction, it's about actually meeting people, like you were saying, where they are, whatever they are actually using, and being able to offer any type of advice that makes that a little bit safer.
We know full well that most people who use drugs never have a problem. And all you need is somewhere that they know they can go if they have questions, if they have a problem, somewhere that is going to give them what they want, and they don't feel like they're going to have a key worker and have a plan. And it's just about widening it out and making it more welcoming for everybody.
Just really lowering the threshold.
That's exactly what I was going to say. I totally agree with that. People can use drugs quite unproblematically, get on with life. Sometimes they might need some help or advice or some input. Other times people will be like fraught with problems. They might find themselves homeless, they might find themselves, you know, estranged from a relationship, or in problems with the criminal justice system. But the threshold for advice and treatments is just too high, because they see a recovery centre, they'll consider a big assessment, they'll consider, even if I do end up going on to treatment, there's no way I'm going to a pharmacy every day. So it's that high threshold, and we've stopped talking about low threshold services. We've talked about the Maryland Centre. We're going to, you know, think about that going forward. What was it like? What can we have again? But that was my first job, and what I'll always remember is that low threshold access. People just coming in, coming out whenever they needed to, not being bombarded with, like, you could be in and out in 2 or 3 minutes, or you could stay for longer, and people sometimes did.
Hello, my name is Chris Rintoul. I'm the head of harm reduction at Cranston. Over the last decade or so, drug treatment and recovery services have expanded throughout England, and that unfortunately has been at the expense of harm reduction services, which have to some extent withered up and died. We see that in our ability to provide people with injecting equipment. We don't see so many people coming to our services as probably would have done in years gone by. And because I moved to working for Cranston in 2021, having had previously worked in various parts of Northern Ireland, particularly in Belfast, in drug treatment and also in homelessness services, I noticed a huge difference between Northern Ireland and England. Because in Northern Ireland we hadn't lost those harm reduction services. In fact, they were separate, and they remained separate, and they were funded separately. And because of that, in those years that England had kind of lost all that stuff, or a lot of that stuff, the expertise in harm reduction in Northern Ireland actually blossomed and grew substantially in that time, such that whenever I moved to working for Cranston, I saw very immediately the difference and the problems that there were, because harm reduction had been an afterthought, or had been lost to some extent anyway. People had told me in those years, you know, people I knew from England had told me, you know, things have changed, it's not great anymore. I'm not really interested in services, I don't go and see them at all. But I thought, you know, possibly that's an exaggeration. But as soon as I moved, I realised that actually is the case and was the case. And we're not blaming anybody for that. That was a drug strategy that came in with the Conservative government, or Conservative coalition, in 2010. And also the austerity measures meant things were much more likely to be cut. And of course they were, and the main cut was to the harm reduction side of the fence, so to speak. So why would I like to see things back again? Because the people that we really need to see coming to drug treatment services like ours, and others of course, are not coming. We're not engaging them, we're not providing them with what they need and want. And we find that when we do that, when we get back to old school street outreach and the principles that underpin that, people engage and lives are changed.
I think the problem we've had over the last decade is organisations have had to respond to policy in terms of what's in local tender specifications, what's written, how you respond to that, and then what you end up with is losing, or I think what we've ended up with is losing some core low threshold harm reduction interventions that were separate and people felt comfortable accessing, whereas now, you know, not many people want to access needle and syringe provision when it's in a treatment centre, because for many reasons that we've talked about really. But, yeah.
It'd be interesting to see if there could be a study done looking at how much equipment can be given out via a kind of harm reduction focused outreach service versus the amount of equipment that could be given out through a static bricks and mortar type service, you know, and just to work out, you know, is there a difference, and if so, why? I think we probably know the answer. There's a little bit, a hell of a difference, you know.
Hi, my name's John Findlay. I'm the National Harm Reduction Lead for Way Through. And when we're talking about harm reduction, we were talking about the little things that can change within services and what we can do today. And I think what we can do everywhere is just really meet people with that kindness when people are coming into service, give people that time. But I think the other bigger things that we've got are, there are some structural changes within harm reduction. We want to see more testing and more checking. We want to see the ability to actually give people really, really detailed advice around the substances that are taken. We're working in a market that is so contaminated at the moment, and so many things that are sold aren't what they are. We need to be able to really tell people, actually, these are the risks, these are the things you can do to reduce those risks, these are the things that you can reduce the harm. And at the moment there needs to be some big changes in terms of legislation and the way that we're able to do that to make that possible. There's also other equipment that we need to be able to give out. Safer inhalation is so important within harm reduction, yet we're shackled by a lot of the things that aren't allowed within the Misuse of Drugs Act and the paraphernalia. Some changes would mean that we're able to engage and really get to grips with some of these things and actually talk to people about the things that they need. And at the moment we can't, because we're not able to meet that need. I think there's lots of things in terms of safe consumption. You know, we've seen it in Scotland, we've seen it in Ireland, let's see it in England and Wales. Let's have a safe place where people who, if they are using drugs, can do so and get that support and get that help and get that harm reduction advice to make that interaction something that is better than what it would have been. It's not about getting that person into treatment, it's not about that person making those changes. It's about making today a bit better than yesterday, and making sure that people have got access to the right information. And I also think the other thing from a harm reduction point of view, there's a whole internet-enabled world where people are interacting with drugs and people buying drugs, and there isn't that advice, there isn't that harm reduction information in there. And we need to get into that space. We need to be bold and we need to be kind in those spaces and really be brave about actually putting advice out there and not being afraid to tell people the real honesty about some of these substances. So I think that's what we really need to do.
We talk a lot about separating out harm reduction services from treatment services. So why is it that we want that to happen?
We were talking the other day, wasn't we, and we said if you don't want treatment, so a methadone script or a buprenorphine script, where'd you go? You know, and I think that led us to a discussion the other day, didn't it, about what does that feel like for someone if you don't feel like they want treatment or they're not able to access treatment or it's not for them. Would you go to a recovery service? I think we know the answer, because that's why we're talking about it.
Yeah, and there's also the fear that you might be pushed towards treatment, that, you know, and that can be really scary for people.
Or if you are on a script, going and asking for needles is difficult for people.
Yeah, you could bump into your prescriber while you're there. What will that mean to your kind of medication regime?
Or somebody can tell your key worker that you've just come in to collect some injecting equipment, and what view might come from them.
Back in the days of models of care, when we had tier 2 and tier 3 services, tier 2 services was that like more anonymous place where you can go, no one, but you knew it wasn't going to affect your script if you were on a script. And I think people will say there's a danger that you can't live in the past, but I think on this occasion we've got to look at what's not working and looking backwards to see what did work back then.
Hope you found that chat useful. Hope there's some things you can take away. Think about what small changes you can make to make your harm reduction services more effective, more instantly accessible to more people.
At its essence, harm reduction is about care. So when you care for people that use drugs, you're already improving the quality of their experience when they come into our services. And as a harm reductionist, our role is to be an advocate. So I would ask you all to go back into your services, into whatever it is you do, and advocate for some of the things that we've been speaking about in this film.